Hey, I'm Dr. Stacy Sims, and I am honored to be giving you this lecture today. Thanks, Mike, for asking me to be a part of your course. Fortunately, I'm back stuck in New Zealand, so couldn't quite make it live. So I'm hoping that this lecture actually instigates some conversation and some interest. And I really wanted to discuss the metabolic considerations and implications for training versus performance of the female athlete. Now, I'm bringing this up because I want people to really realize that training is different from performance. And I'm saying this because we're hearing a lot of chatter in social media, other popular media platforms, that there is no menstrual cycle phase effect. There's no evidence for looking at menstrual cycle effects on different physiological outcomes for the female athlete. Now, I want people to understand that performance is one point in time. So if I were to say, everyone, let's go do counter movement jump on day 4, 5, 6, and day 21, 22, 23 of our menstrual cycles, we probably wouldn't see that much of a difference because the psychological supersedes the physiological, and it is just at one point in time. We have lots of other variables to consider. But when we talk about training, this is when we're looking at that chronic adaptation and the chronic load, and we can take advantage of different aspects within our cycle to actually garner the benefits for training. So as I go throughout this lecture, I want you to really keep in mind and understand how training is different from performance and how we actually got here or where we are today to be having this conversation. So to give you a little bit of historical context of how it is just now in 2021, almost 2022, that we're starting to talk about female athletes in a different context from men, how we might need different nutrition needs, training methods, really understanding that women have menstrual cycles, we go through perimenopause, postmenopause. So when we look at the history and context of it, most of the standards and reference norms are shaped by gender norms. So we know that the default is often men. So this is why we know that most of the data out there, especially sport nutrition, is based on 18 to 22-year-old college-age men. That just is the standard. It gets defaulted. And we also know that gender norms influence the choice of the reference species. So we know that more college-age men will volunteer for different performance studies. We also know that women feel excluded. They don't feel like they can actually be on the same playing field as men when it comes to performance research, and they're often dissuaded from actually participating. So then we look at the generalization of the data that comes from the male studies, and we bring them over to the women, assuming that women are small men, but we know that women are not small men. Then we also know that the reference subject influences the gender norm. So again, more of the men and young adolescents will participate and say, yep, I'm good for this. I'll do a muscle biopsy. And it's more exclusionary for women. So it's a combination that we have to include more women in our research designs, but also encourage women to participate in the studies themselves. And then the last point is the standards often assume a sex binary. So most models in system biology are biased towards a cis male default. And even artificial intelligence language and structures are dominated by men. Most of the algorithms that we see in a lot of the uptake of the AI is from that male lens, except for a few. Some of the femtech out there is actually AI derived from women and women's point of view and algorithms. So we look at that history and context and how it drives it into the sporting context. So we know that if we're only seeing men on TV, we're only seeing men in the literature, we're only seeing men in that sport and society idea, then in general, we get the impression that women don't belong in that particular system, which again decreases women's participation in sport, in research, and the inclusionary of women and menstrual cycles, etc., in the study design. So the more that we see the norm of the male model being what we should be generalizing from, the more that's accepted. So we have to look at how are we changing that, and that's the conversation now that's happening, like I said, in 2021, that women are not the same. So we're starting to see more and more women coming out saying, I need more specific things for me. So this is part of that sporting context that I'm going to be pulling in through this lecture as we talk about things. We also know that we talk about success in sport, it's associated with the masculine traits such as power, aggressiveness, and strength. So when we start talking about women's needs being different from men's, a lot of the scope comes that women are more like a delicate flower, that we need to have special compensation for women because they're not as strong or aggressive as men. And we know that that's not true, but it is that sociocultural context that most of us has grown up in, saying that yes, women have a menstrual cycle, but it's that time of the month, we shouldn't talk about it, or they're very delicate at that time of the month. So it's those myths that get perpetuated within successive sport performance, research, and the guidelines that we then have with sport nutrition. But I really want to bring it back down to how it all starts. We talk about sex differences, biological sex differences, not the construct that we understand as gender norms or how we identify within society. Coming back down to the biological mechanisms of sex differences. It's driven within physiology that there are inherent sex differences within muscle tissue, mitochondria, the way brain functions, neurotransmitter. Now we're even looking at sex differences within the gut microbiome that are derived from birth and not necessarily from an epigenetic exposure. So when we talk about sex differences in metabolism specifically, it's usually attributed to our sex hormones or gonadal hormones, but we know that there's an independent contribution of chromosome complements to metabolism. So we know that there are 46 chromosomes and there are 2 sex chromosomes, the XX and the XY. And the XY dosage is associated with increased adiposity, insulin resistance. This is also a really important determiner when we're talking about postmenopause and how women become more insulin resistant and increase more visceral fat. We also know that the X chromosome dosage drives the increase in appetite when we have a circadian shift. So when we're looking at night shift, when we're looking at night missions for female and military, when we're looking at how this is an epigenetic exposure and not a hormonal exposure, we have metabolic gene expression that comes with circadian shifts, which then again alters leptin sensitivity and subsequent appetite. So we know from the get-go, without investigating female sex hormones, there are sex differences within the metabolic scope. The other thing to remember is even within the muscle tissue itself, women have more of the proteins within the mitochondria for metabolizing and using free fatty acids. So those are what we call the actual biological sex differences. But what we know is that most research investigates the epigenetic influences of sex hormones. So when we start talking about the needs of women versus men, we often are discussing what happens after puberty when we have the epigenetic exposure of estrogen and progesterone and how this influences every system of our body. So let's just have a quick look at what female sex hormones we're talking about and how they drive different aspects of what's happening within our body. So we know we have estrogen and progesterone. Those are the 2 dominant female sex hormones. But when we drive it into a better consideration, we have 3 types of estrogens. We have estradiol, E2. This is what we usually talk about when we talk about estrogen. We have estriol, E3. This is what is produced in pregnancy, and it's very weak. And we have estrone, E1, which is the predominant estrogen in postmenopause. It's 10 times less potent than estradiol, E2, and it has different metabolic influences. We know that progesterone has anti-estrogenic effects, knowing that estradiol and progesterone, we look more at the ratios. We have more of a concern of the ratios than the absolute numbers. We have the follicle stimulating hormone. So this stimulates the growth of the ovarian follicle for ovulation, which increases estradiol production. If we have a suppression of FSH, then we won't have that growth of the ovarian follicle. And then we also have luteinizing hormone, and in women, it is a pulsatile hormone, so it pulses every day, and it stimulates the ovaries to produce estradiol. So when we have a suppression of LH, we also don't have the expression for increasing estradiol. And across the lifespan, women do have testosterone, and it's relatively constant dose throughout the entire lifespan. So there's not wild fluctuations of testosterone like there is estradiol and progesterone. So this is your basic schematic of a normal menstrual cycle. So just for textbook purposes, we're talking about day 1 being the first day of your cycle or the bleed phase. which is usually day 1 to around day 4 or 5. With spotting afterwards, we have day 14, which is around the time of ovulation. So we have that LH surge right before, that surge of estrogen right before. Then after ovulation, estrogen takes a little bit of a dip before it comes back up. And we have progesterone that's produced from the corpus luteum from ovulation that rises, and we have that mid-luteal peak of both estrogen and progesterone, remembering the ratios, before they start to take a dive and we start into our next cycle. So that's a normal schematic of a menstrual cycle of our hormone perturbations. Then we start looking at oral contraceptive pills. Now, oral contraceptive pills contain both estrogen and progesterone. It's the estradiol component that we often talk about for the most part having systemic effects, but it's also the generation of the progesterone or the progestin that has similar or has some additional effects that our natural progesterone does not. And I'll get to that in a little bit. But the thing to remember here is when we look at the perturbations of an OC, you take the pill in the morning, it spikes, and then it comes back down. So you have these little perturbations of estradiol and progesterone for 3 weeks. And you have an accumulation of these exogenous hormones, which then have a peak and then drop off for that sugar pill week here, or that placebo week. We know that the first 5 days of the active pills, the body is very similar to the follicular phase of the natural menstrual cycle. And then as these hormones accumulate over the next about 3.5 weeks, we see a decrease in the body's ability to withstand strain. We see a decrease in the body's ability to recover. And this is across all systems. It's the accumulation of these synthetic hormones that cause systemic effects. And then we also know that after 3 days of the sugar pill week, or the sugar pill, we see the same recovery responses and adaptation responses as the natural follicular phase of a natural cycling woman. So the phase differentiation here is completely different from your natural cycle. The other question I often get is, well, what about an IUD? So a progestin-only IUD, the Mirena, the Aquila, or the Skyla, it has a small dose of progestin that changes the endometrial lining. So it becomes really thin. So if we see normal ovulation up here, and then we start seeing endometrial resting state with the Mirena, we start seeing less of a perturbation and build to around 6 months. It starts to flatline to the point where you might not even have a bleed because the endometrial tissue is so light that it just gets uptaken again by the body. We know that ovulation occurs after about 6 months of insertion, so women who are interested in tracking their cycle, they still can by using a basal body temperature and ovulation predictor kit, and if they want to dial in blood tests, they can. So it's really 3 different schematics that we're looking at when we're talking about menstrual cycle and the way hormones affect female athletes and female athlete physiology. So the basic idea I want you to bring forth of this is, what is the goal of the luteal phase of the natural cycle? So the goal of the luteal phase is to build tissue. This is why we have estrogen and progesterone. So after ovulation, you have the changeover of estrogen and progesterone coming up, all with the idea of building that endometrial lining in case an egg is implanted and you start to have a developing fetus. So what happens in this phase here is we have an increased use of amino acids. Why? Because we're building tissue. We have higher natural or resting energy expenditure because we're building tissue. So women's metabolic rates go up in the eye that their body is very active in building tissue. They have an immune response that changes as well that requires more energy. We have a shuttling of carbohydrate from the liver and the muscle to provide more carbohydrate for the endometrial lining. So we have more stored glycogen in the endometrial tissue and more phospholipids that go with that into the endometrial tissue. We have an alteration in insulin sensitivity and GLUT4 activity so that we can have more available building blocks for that endometrial lining. So why am I explaining all this basic biology? So as I was saying, we know that estrogen and progesterone, they're not in isolation, and they can work to counter each other. They can also work to enhance each other's actions. But when we look specifically, estrogen stimulates tissue growth, but progesterone stops it, so it promotes cell death. It is responsible for the sloughing and the losing of the endometrial lining. Once that progesterone and corpus luteum stops producing progesterone and progesterone drops, that's the signal for us to have that bleed pattern. We know that estrogen stimulates the contraction of the uterine muscles, whereas progesterone decreases it and it's more of a relaxant. We know that estrogen promotes edema or fluid retention, so this is our plasma volume expansion, but we know that progesterone can supersede it and cause a plasma volume retraction in the high hormone phase. We know that estrogen in some regards is pro-inflammatory, and we have progesterone that counters it, which is necessary because we have an immune response that's different between the phases with a pro-inflammatory response in the high hormone phase. So progesterone is helpful in suppressing that. We also know that estrogen promotes immune activation. So this is where we're talking about our activation of macrophages. But when progesterone comes aboard, it is immunosuppressant. So this is where some of the new research within COVID and COVID vaccination is looking at menstrual cycle phase-based vaccination, more of an eye to having it done in the low hormone phase when estrogen and progesterone don't have these antagonistic effects. So let's look specifically at some of the key functions of estradiol. We know that estradiol is responsible for muscle protein synthesis at the basal cell level. It's responsible for glucose homeostasis in the skeletal muscle. It has a significant mitochondrial function, and it also has a direct action on the myosin contractile proteins for force generation. The other aspect to think about is our motivation or our mojo, and estrogen has a direct effect on that. It has a significant effect on serotonin and serotonin receptors. When there's an upsurgence of estrogen, it hypersensitizes serotonin. So we have that hypersensitivity of more serotonin receptors being activated. And when we're looking at a downward effect of too much estrogen, hyperactivation of serotonin receptors, when estrogen starts to fall, serotonin drops off, and we can have a serotonin dump and depression, anxiety. So this is where we see a lot of that occurring in your premenstrual syndromes right before the bleed phase. So we also know that estradiol is very specific for appetite regulation as it affects the hypothalamus and Arcus peptin neurons. It's also responsible for thermoregulation in the hypothalamus. It's responsible for bone and bone regeneration. It stimulates the secretion of cytokines involved in bone homeostasis. And from a carbohydrate standpoint, it does moderate blood glucose homeostasis. It stimulates more GLUT4 translocation, so we can have more insulin sensitivity with estradiol on board. We look at progesterone. We know that progesterone key functions is to be catabolic, primarily to release the building blocks for endometrial lining. So we have an inhibition of muscle protein synthesis. It decreases contractile strength because it's breaking down that muscle tissue. It is neuroprotective because we have more inflammation. We also have the breakdown of tissue. During that luteal phase, it stimulates women to have an increased pain tolerance. We also know that it's critical for bone density and decreasing the rate of bone reabsorption. And we also know from a metabolic standpoint, it increases the autonomic nervous system. So in the high hormone stage, when progesterone is elevated, we have an increase in respiratory and heart rate. We have an increase in the core temperature. And again, it can be anti-inflammatory and keep pro-inflammatory cytokines kind of under control. So this is a sport nutrition lecture. You're probably wondering what is going on here. She spent the past 20 minutes talking about hormones, but I'm getting there, trust me. I really want you to understand these hormones and how they affect every system of the body, because they have unique effects when we're talking about metabolic control for women. So we know that hormone-driven perturbations from an estrogen standpoint is it decreases reliance on hepatic glycogen. So it spares your liver glycogen. So you end up with more muscle and liver glycogen in the high hormone phase, but that doesn't mean it's accessible. And this is where we start to get into a little bit of a conversation further down the track in this lecture. It increases fatty acid utilization by stimulating lipase and some other aspects within the muscle mitochondria, so that we increase our reliance on free fatty acids. It decreases our post-exercise growth hormone release. And although estrogen is anabolic in isolation, there's only one point in time where we find it in a high ratio to progesterone, and that's right before ovulation with that estrogen surge. And this is where we often see women who have the ability to go hit a PR or have a really high, strong training stress point and recover really well with the aid of estrogen. When we talk about progesterone from a metabolic standpoint, it competes with aldosterone. So aldosterone is our fluid regulatory hormone that is responsible for sodium balance. So when we have more progesterone on board, our body kicks out more total body sodium. This is why women tend to be on the borderline of hyponatremia in the high hormone state. Also, in various forms of oral contraceptive pill use, we can see a higher borderline of hyponatremia. As I mentioned before, it increases protein catabolism and decreases protein synthesis, and there are greater lysine and leucine needs due to this. We have an increase in respiratory drive and heart rate because of the autonomic nervous system effects that it has. And again, it counters glycogen storage because it decreases GLUT4 translocation. And the goal of progesterone is to shuttle that carbohydrate that would usually be going into the liver or the muscle to the endometrial lining to make it glycogen rich. So how does this actually affect training? Remember, we're not talking about performance, we're talking about training. So how does it affect training? So I'm bringing up the schematic because when we look at the recommended right now daily carbohydrate needs for athletes, we see that this almost everywhere in every practitioner, from the dietetics, position stands and such. So this was actually a combination. We're looking at a joint position stand between ACSM, the Academy of Nutrition and Dietetics, Canada, and MSSE. So we're looking at 3 to 5 grams for light, all the way up to 8 to 12 grams carbohydrate in extreme activity, ultra endurance, double sessions, that kind of stuff. Let's take a little bit of a closer look, right? So me being me, I have the position stand and I look, there's 157 citations in there. And going through them, I'm really keen looking for what's applicable to women to make sure that they just didn't generalize. So of those 157 citation, there were 16 associated with women. 157, 16 for women. Of those 16, 7 were on low energy availability, bone and menstrual dysfunction, so pretty much the female athlete triad, and or red S. We have 7 on iron deficiency and causes of iron deficiency. We had 1 on dairy and protein intake promoting fat loss and lean mass gain in obese premenopausal women. And we had 1 on fluid milk intake and body composition in untrained premenopausal women and resistance exercise. So when I look at this, none of those inform carbohydrate needs or recommendations for women, yet this is the position stand and these are the guidelines that so many people are honed onto, and practitioners suggest to their clients, these are our carbohydrate needs and our carbohydrate guidelines for optimal performance and training. So what is it about it? Why can't we generalize, right? So we know there are sex differences in fueling, where men will use more of their muscle and liver glycogen. Women tend to use more of their blood glucose especially when we start getting into more endurance and we start looking at the high hormone phase. Women have a greater capacity for burning fat at a given intensity, which again spares glycogen. And this changes across the menstrual cycle and changes with OC use as well. But we want to really look at that estradiol to progesterone ratio because this is a stronger representation than our absolute values of hormones. And this is where it becomes a little bit more individual. Another reason why it's really difficult to write generalized guidelines. But remembering that estrogen spares carbohydrate, increases free fatty acid oxidation, suppresses liver glucose production, whereas progesterone enhances fat storage, decreases muscle glycogen storage because it inhibits insulin receptor expression, and it diverts glucose to the endometrial tissue and liver. So if we're in a high hormone phase, then we're having a lot of carbohydrate that's not making it to where we need it to be with regards to the working tissue. So when we take it into a lab aspect, compared to equally fit men, naturally cycling women have a lower respiratory exchange ratio and glucose rate of appearance and disappearance during moderate intensity endurance exercise. Women use less muscle glycogen for the same intensity and workload, and they use more blood glucose, sparing hepatic glucose as well. And this is a bigger sex difference when we look between the menstrual cycle phases, with more of that carbohydrate sparing happening in the luteal phase. So when we compare the mid-follicular to the mid-luteal phase, the mid-follicular being low estrogen and progesterone, mid-luteal is at that peak of estrogen and progesterone. In that mid-luteal phase, we see there's a lower glucose rate of appearance and disappearance, and there's a metabolic clearance rate. There is a reduction in our respiratory exchange ratio as compared to the mid-follicular. So this all indicates there is a lack of tapping into glycogen as well as storage of glycogen, and it indicates a greater free fatty acid reliance for women. So when we take it into more of an exercise performance standpoint, when we look at women who were carbohydrate depleted and they were not allowed supplementation, they were able to maintain blood glucose during the follicular phase, but not the luteal phase. Now remember, as I said earlier, women rely more on blood glucose for exercise, whereas men rely more on muscle glycogen, tapping and really digging into those muscle and liver glycogen stores where women don't. So our cycling time to performance is fourfold greater in the early follicular over mid-luteal in these depleted states without supplementation. But when we start looking at what happens if we give supplementation during that luteal phase and we have that exogenous carbohydrate coming in, it minimizes the difference between the mid-follicular and the mid-luteal phase. So it's looking at the timing and the fact that women need more carbohydrate supplementation coming in that luteal phase because of these reduced carbohydrate kinetics. Then we often hear about carbo loading. Let's carbo load before a big race. And the idea is to supercompensate glycogen stores. So we already know that in the luteal phase, we already tend to have a relatively higher amount of stored muscle glycogen than we do in the follicular phase, primarily because we can't access it very well. So we know that skeletal muscle and liver glycogen storage varies across the phases of the menstrual cycle, and this can directly influence how carbohydrate is uptaken and the responses in women. What we do know is to achieve 50% of what men can load, regardless of menstrual cycle phase, women need to eat 35% more total daily energy with a higher percentage from carbohydrate. And that's to make sure that they're getting enough calories as well as carbohydrate to try to supercompensate. But again, it depends on the phase and the fitness level. When we're looking at the high hormone phase, there's less supercompensation than the low hormone phase. But the biggest thing here is that there's no performance improvements with increased glycogen because those hormonal influence on the glucose kinetics plays a bigger role on how your body's going to be fueling. So it's a much better option for women to really look at what are they doing in and around the luteal phase to supply carbohydrate to be able to hit those workloads and intensities that they want to, and how to incorporate that into a training schematic if they're cycling their macronutrients across the menstrual cycle, to really dose up a little bit more with carbohydrate in the luteal phase to maximize their training adaptation and training stress. So then we get to our other favorite macronutrient. What about protein? Protein becomes a big rage, and I think it still is a big rage. So we know that the general recommendations from American College of Sports Medicine is 1.2 to 2 grams of protein per kilogram of body weight per day. But when we look again at how this came to be, it's based on resistance-trained men, and then the recommendation for women is just compared to non-active men. So what is our nitrogen turnover in non-active men? Well, that becomes what women need as female athletes. Until recently, when people started really looking into the kinetics of protein turnover and the timing and whole body anabolism, so they looked specifically at resistance-trained women in this 2019 article and found that the dosing of protein post-exercise needed to be up, and depending on the duration, it was very similar to that of men. So we know that the general recommendations for female athletes is too low. The outcomes of this one particular study was that women needed to dose higher, and we start looking at endurance athletes and the literature coming out on endurance athletes and protein needs. They too are up around that 1.8 to 2.0 grams per kilogram a day. When we start adding in calorie restriction, we need protein, and we need to increase our protein, because the first thing that goes when you're in calorie restriction and trying to exercise, of course, is muscle mass. And women already are compromised in building lean mass and keeping it. So if we have calorie restriction plus exercise and we don't have enough protein, then we are going to lose more of our lean mass and not our fat mass. So the considerations for our protein intake, again, come down to our estradiol and progesterone ratio. It's really significant to consider when we're talking about individual protein requirements, because women's cycles are very unique to themselves. It's their own lived experience. And when we're looking at our estradiol to progesterone ratios, this can really influence how we feel, how we perform, and what our possible requirements are from a week-to-week point of view or phase-to-phase point of view. In general, though, we know that progesterone is catabolic. It increases amino acid utilization, it decreases muscle protein synthesis, because the goal of progesterone is providing the building blocks for that endometrial lining. We also know that low carbohydrate availability in the luteal phase, because we can't access it, increases amino acid oxidation during exercise in this phase. So all in all, we're talking about the high hormone phase and that upsurgence of estradiol and progesterone. We need to increase our daily protein requirements around 12%. We also know that there are sex differences that become increasingly apparent with age, both in response to feeding and exercise, knowing that women don't age in a linear fashion like men do. Women have perimenopause and postmenopause, which tends to be in and around their mid-years, around late 40s, early 50s. It has a significant impact on muscle protein synthesis, lean mass accrual, insulin responses. So women don't age in that same linear fashion that men do. So when we're talking about it, we have to understand how fit the woman is compared to the men. If we're looking at a recovery window, we know that nutrient timing is super important, especially if we're trying to build lean mass. And there is a sex difference in return to baseline. So when we're looking at metabolic influences and how fast women recover and come back down to baseline, due to those inherent metabolic fueling differences, we see that women come back down to baseline within around 90 minutes. And what I mean by baseline is their pre-exercise resting metabolic rate. For men, that can be anywhere from 3 to 15 hours, depending on and that intensity and what they were doing. So that recovery window differs. It also differs on if it's resistance training or if it's endurance. We also know that from a sex difference point of view, there are dosage differences. We hear all the time of 20 grams of whey protein or 20 grams of protein post-exercise is about what we can get away with for maximizing muscle protein synthesis. But when we look at resistance training and intensity work for premenopausal women, we see that that 30 gram, even all the way up to a 40 gram dose, can still be used for muscle protein synthesis and accrual. And when we get to that postmenopause or that peri and postmenopause state, because there's an anabolic resistance, we need that 40 gram dose post-exercise because we need the mechanics of exercise and the stress of exercise within the muscle to encourage that protein uptake, which will then encourage muscle protein synthesis. So we often hear a lot about hydration too. We hear, I feel like we're talking about always pushing the dogma of drink to thirst, no, drink on a schedule. And again, these recommendations are based on primarily men. And we know that there are inherent differences again when we're looking at hydration status and menstrual cycle effects. So estrogen and progesterone have specific interactions when we're talking about fluid balance and fluid regulation. So estrogen is responsible for maintaining plasma osmolality, and it is responsible for stimulating arginine vasopressin. It also affects what we call the aquaporin 2 channels within the kidneys, so it increases fluid retention. It also has a very tight regulatory control for vasodilation with regards to the nitric oxide cycle. So when we're looking at when estrogen comes up and we have edema or fluid retention, it's based on these mechanics behind our arginine vasopressin and our ability to retain fluid, which will then alter our baseline plasma osmolality. So we know that women will sit in that osmotic range of around 283 to 290. And then when we're looking at what happens across the menstrual cycle, we see it drop down to closer to that hyponatremic range, which sits around that 270 mark. And that has to do with the way that estrogen is affecting our osmoregulation, just shifting everything a little bit. Where progesterone has a counter effect where it is a longer term look for fluid regulation. So progesterone is more involved in the renin-angiotensin-aldosterone circuit. So it counters aldosterone by attaching to the same receptor site. So again, we have more total body sodium that is kicked out when we have an elevation in progesterone, which again contributes to that lower baseline of plasma osmolality. It also inhibits atrial natriuretic peptide, or ANP, which is also responsible for kicking out fluid. We know that with oral contraceptive pills, we have a lower plasma osmolality threshold for thirst stimulation, so we have less dehydration that occurs with an increased drive for thirst. So their original ACSM position stand identify the fact that sex differences in renal water and electrolyte retention are subtle and not of consequence. So when we look at the fact that we've just been dismissed and we see that there are specific effects of estrogen and progesterone, again, it makes me question our position stands. So we know that there are specific sex differences with regards to sweat rate, sodium concentrations, and sweat sodium losses in athletes. This was done by Lindsay Baker and her colleagues. It was a really good study back in 2019. They found that men and women per hour, women of course have a lower whole body sweat rate, primarily due to body composition differences, and also women will vasodilate first before they start sweating. And in the luteal phase, that onset of sweating is shifted because we have an increase in core temperature that then changes all of our thermoregulatory mechanisms over to a higher set point. We know that the rate of sodium losses is lower in women, and this has to do with our interplay of estrogen, progesterone, and our fluid regulatory hormones. And our whole body sweat rates, my picture's in the way, but women again have lower total body sodium losses as compared to men per hour. When we look at what's going on here, and this is a study on fluid balance responses across a 3 to 3.5 hour race. So when we're looking, an 8 to 8.5 hour race. So it was a very long endurance race. We see that hydration status, or how much fluid was taken in, wasn't really that different between the men and the women. Men took in a little bit more water, women took in a little bit more sports drink, which is great. So when we start looking at dehydration, or the amount of 2% body mass loss, men are able to sweat more, lose more muscle glycogen, and have greater total body mass loss as compared to women. So we're looking at women who are hitting that dehydration mark. They really are losing a lot of plasma volume. Our finished sodium concentrations, very similar, but for women, a greater amount of hyponatremia rather than 0 at hypernatremia. So the outcome of this is that women will finish a long endurance race either at normal blood sodium levels or slightly hyponatremic. And this needs to play into how we are advising women in hydration status. We also know we can't tell women to drink to thirst, because thirst mechanics and thirst sensations change across the menstrual cycle if you're using an oral contraceptive pill or not, if you're peri or postmenopause. So across the lifespan, our thirst sensation changes, becomes muted when we have more time in a high hormone phase. And we also know that if we're saying drink on a schedule, we have to be super careful, because women can end up with a greater risk for hyponatremia. So a lot of the considerations and questions that still come out and haven't been answered really well yet in the literature. Kate Wickham at Copenhagen, originally from Brock, is doing a really good job on this. She just wrote a fantastic review that came out last month on female athlete and hydration considerations. But we have to think about there's a phase difference in sodium excretion. There's a phase difference in thirst stimulation. There's also an oral contraceptive pill effect on both of these. We know that plasma osmolality, the baseline plasma osmolality, changes across the phase as well as OC use. And there's an increased hyponatremic risk in the high hormone phase. And it has to do with the fact that the hormones alter our thermoregulatory thresholds. So it changes, especially with progesterone being very, sorry, just lost a word, progesterone increasing our core temperature. It is one of the biggest instigators for changing our thermoregulatory thresholds. So we also have to ask, what are our ratios of E to P, how that might be affecting our fluid regulatory hormones? What are the cumulative effects on thermoregulation and hydration? And then we also have to look specifically at dehydration effects on performance in women, because women tend to lose less total body mass, and we don't know what those limits are for women yet, because we've just been generalizing from men. We can see men will lose 3, 5, 6% of their body mass from glycogen and water and still perform well. But we don't know what that upper limit is for women yet. We also don't know if there's a phase or an OC effect on dehydration and effects on performance. So these are still questions that need to be asked before we can actually put out specific guidelines for fluid intake in women across all sorts of endurance adventures. So the other thing that I want to get into is menstrual cycle phase-based supplementation. So we hear a lot about creatine, we hear about iron, magnesium, beta-alanine, a whole bunch of other supplements that we need to take. But I just really want to focus on two here. I want to focus on iron and creatine, because these are very interesting because they have very specific phase-based responses. So we talk about iron, right? So we know that women are more predisposed to anemia. So 15 to 35% of female athletes are iron deficient, so either with or without anemia. So that might mean they are low in iron, but they're not quite at the point where their ferritin has dropped out. This is an increased risk with heavy menstrual bleeding, we have low vitamin D levels, we have low energy availability, endurance exercise, and perimenopause. So all of these increase the risk for women to have iron issues. The other thing that we don't talk about much with regards to iron control in women is hepcidin. So exercise induces an inflammatory response, and with regards to inflammation, hepcidin activity increases for 3 to 6 hours post-exercise in premenopausal women, and up to 24 hours post-exercise in postmenopausal women. So with this increased inflammation, we can't absorb iron from the gut. So we have this decreased ability to absorb and recycle iron from the gut. And with iron deficiency, this mechanism is a bit downregulated because the body's like, wait, I need iron. So it kind of mutes hepcidin. But for women who are on the very low end of normal, they can't get ahead of their stores if they're not actually supplementing appropriately, because they're exercising, they have this increased inflammatory response, they might be trying to supplement, but they just can't absorb it from the gut, and they're always going to be on that low end of normal, just can't get on top of the stores. So we start really looking at how iron is regulated. We know about hepcidin, it's the main regulatory hormone. It controls absorption of iron from the food and the distribution of it around the body. So it's upregulated by inflammation. So we know that it goes up post-exercise, it goes up in perimenopause when there's a systemic inflammatory response within the body, and chronic stress. It's downregulated by times of higher estrogen, testosterone, and vitamin D3. So erythroferrone is the other regulatory hormone, and it regulates iron supply for red blood cell production, and it also suppresses hepcidin. So we want to look at times where we can supplement with estrogen being up, increasing our vitamin D3, and looking at how we can maximize erythroferrone. So we look at that across the menstrual cycle. We see areas of the menstrual cycle and when we can actually supplement and absorb the iron. We know that hepcidin is high in the first few days of the follicular phase because we have a lot of inflammation going on. But it drops. As the bleeding subsides, it drops. We also have this upsurge of estrogen. We know that estrogen suppresses hepcidin as well. And then after ovulation, progesterone starts to come up. Estrogen starts to come up. Progesterone-estrogen ratios are what we're concerned about here, and we know that there's a pro-inflammatory response in the high hormone phase from an immune and an interplay between estrogen and progesterone, so hepcidin comes up. So if we're looking at supplementing to really get on top of that low iron store, we want to look at supplementing in the early to mid follicular phase and around ovulation. So we can maximize that body's response to downregulating hepcidin and maximize our body's ability to absorb iron. We talk about creatine as well, and Dr. Abby Smith-Ryan has done quite a lot of good work on this as well, and I wanted to highlight some of what she's brought to the table here. So we know that creatine is an amino acid, and it is needed for every high energy, energetic kind of system that happens in the body. So we know that it's needed for brain function, it's needed for muscle contraction, high intensity work. We know it's needed for gut and gut integrity. We know that it is needed for brain and neurotransmitter health. So every time there's a high energy need, and then we need creatine. Now the thing about it is women have 70 to 80% less stores than men, and we tend to go through it quickly. We also know that it changes across the woman's lifespan. Our creatine kinetics, so the older we get, the less we have, but probably the more we need, especially for brain health. Our endogenous bioavailability changes across the menstrual cycle. Again, if we're looking at energetics and how the body is using different fuel and what it's using for building blocks, we're going to look and say, yeah, okay, well, in the high hormone phase, we know that there is a high need for creatine. There's a high need for all of those building blocks because, again, the goal of that luteal phase is to build tissue. So creatine kinase is influenced by estrogen, and it reduces the endogenous production. during phases of high estrogen. So this is around ovulation and in the luteal phase. So if we're reducing our endogenous production, this is a time to supplement. So we can uptake it more. Our body is using it, but we can uptake it and store more of it. So it's more effective to do our dosing and loading and starting in the luteal phase. Also, when we're looking at things like concussion recovery, and we know when women are having issues between being hit in the low hormone and the high hormone phase, if we supplement immediately with creatine, if they get hit in the high hormone phase, the outcomes are much better than if they don't supplement with creatine in that high hormone phase. So creatine supplementation is something to think about when we're talking about menstrual cycle phase-based aspects of nutrient timing and when we're taking things in. So again, we're talking about creatine across the menstrual cycle. My big picture was gone, so I had a little schematic there of just really showing to increase our body's uptake in that high hormone phase because we're not producing a lot, so our body's able to store more. So I'm bringing this picture up of Catherine Switzer. She actually now lives in Wellington here in New Zealand, but she has been kind of a role model and iconic because she's one of the first people who was like, what do you mean I'm a woman? I can run that far. And it was like the beginning of not necessarily feminism, but the recognition that women can be involved in sport. And this is the image that we need to keep thinking about when we start looking at the new research that's coming out and how we're hearing lots of people saying no evidence, no evidence, no evidence. When we look down into the bones of the research that's coming out and the newer stuff that's coming out with really sound methods and scientific design, we are seeing that there is evidence to be a woman, to supplement, to control what we're taking in from a training perspective. We want to enhance our chronic adaptations. We want to work with our body's own physiology to allow those hormones to complement what we're doing. So yes, there is no performance difference between phases or OC, but when we're talking about chronic adaptations and how we can manipulate things that we're eating and how we can manipulate our training, we have to have an eye towards what's happening with those hormones. We have to have an eye towards what our general recommendations are, knowing that most of the guidelines are just from that standard default reference model of a college-aged male. So I really just wanted to put this information out there to get you guys to start thinking about what you're reading, how you're assessing, what your guidelines are, and how you can really benefit working with women's physiology and understanding the influences, not only from sex differences at birth, but the epigenetic exposure of estrogen, progesterone, and how they change across a woman's lifestyle. So you can find me if you're more interested in a little bit more of what I do. Social media, Dr. Stacy Sims. Also at Auckland University of Technology, we have a female athlete health and research program that's up and running. And just wanted to also take this time out to say thank you, Mike, and I hope you guys got a lot of stuff out of this lecture. Thanks.